Hello, a great pleasure to be here. I'd like to thank the program committee for selecting my submission for an oral presentation. It's always a great pleasure. I would like to talk about the changes that occur within and beyond the auditory cortex in humans upon sedation and loss of consciousness during induction of general anesthesia. Generally speaking, figuring out neural signatures that are associated with changes in sensory processing across states of awareness is really one of the major foci in modern neuroscience. And this topic is not only of fundamental importance, but also is of clinical relevance. And clinically relevant conditions, for example, include sedation and loss of consciousness under general anesthesia, natural sleep and sleep disorders, as well as different disorders of consciousness. Previous non-invasive studies, ERP and functional neuroimaging studies, have shown that during induction of sedation and general anesthesia with propofol, which is an agent that's commonly used in the clinic for induction of general anesthesia, propofol has differential effects on auditory processing, responses to sound stimuli in early primary and higher order non-primary auditory areas. Now, direct recordings, invasive recordings in humans are possible in epilepsy patients in the setting of a neurosurgical clinic. And of course, these invasive intracranial recordings, or ECOG, electrocorticography, they offer high spatiotemporal resolution. So previous intracranial studies from our group have demonstrated that there was a functional heterogeneity in effects of general anesthetics, be that propofol or other agents, on responses to click trains, such that here on the left we see that responses from the lateral surface of the superior temporal gyrus, which is a non-primary auditory area, are more sensitive to propofol than responses in Heschel's gyrus, which is where primary auditory cortex in humans is located. Later, we found that within Heschel's gyrus, the most posterior medial aspect of it is more resistant to effects of propofol compared to the more lateral areas. In the present study, we took this a few steps further, and rather than using click trains in a passive listening setting, we employed more complex stimuli, sequences of vowels. So these are 5 vowel sequences, 4 of which are identical, and that's what we'll look at, responses to these initial 4 out of 5. These vowels were presented to these neurosurgical patients in the operating room when they were brought in the operating room for the removal of these intracranial electrodes after what generally is a 2-week monitoring period. And we had the luxury, since temporal lobe epilepsy, well, obviously, usually happens somewhere in the temporal lobe, and that's where primary and non-primary auditory cortex is in humans. We had the luxury of very extensive coverage of relevant areas that are involved in auditory processing. That includes primary auditory cortex in posterior medial Heschel's gyrus, surrounding non-primary areas in the superior temporal plane and on the lateral surface of the superior temporal gyrus, surrounding auditory-related areas, as well as prefrontal cortex. So typically what happens with these patients is that we would start the first block without propofol for 10 minutes, and then we would gradually increase the infusion rate of propofol while monitoring their depth of anesthesia using BIS index on a minute-by-minute basis. And we would collect 3 to 4, generally 4 blocks of experimental blocks with those vowel sequences while the subjects were performing a target detection task. And we would measure observers' awareness, assessment of alertness and sedation, which is basically clinical way of estimating depth of sedation before and after each block. And based on that, and as well as on their performance in this task, we would label these blocks as corresponding to an awake, sedated, or unconscious state. And then when we align these, so from the 9 subjects, we pick three blocks, you can see there is a pretty good correspondence between their BIS values and the OAS values. So just to give you an idea of what these responses look like, here are exemplary data collected from 4 sites at 4 different levels of auditory cortical processing hierarchy, beginning at the top with primary auditory cortex, and then STG, non-primary area, auditory-related cortex, and prefrontal cortex. What you see, and the 2 principal metrics that we use to measure these responses are average evoked potentials, shown here in blue, and high gamma power, which is measured in the range of frequencies between 70 and 150 hertz, shown in red. So you can see that these vowel stimuli, they elicit robust responses in auditory cortex proper, and these responses are generally relatively resistant to induction of general anesthesia, as can be seen by comparing left to right. The 3 columns correspond to the 3 states of awareness. In contrast, responses in auditory-related cortex and prefrontal cortex are weaker to begin with, and they are more sensitive to, they become attenuated upon sedation and further attenuated upon loss of consciousness. In addition, I would like to bring your attention to this feature of response that is evident here for the core auditory cortex. That's what we call envelope following response, right? That's basically tracking of the temporal envelope of the stimuli, where there are 4 peaks. So we'll get to that in a couple of minutes. So I just showed you what typical responses look like in individual recording sites in a representative subject. This is what happens when we pull data from all 9 subjects. So here I'm plotting on this in the standard coordinates. I'm showing you all the electrodes pulled across 9 subjects, which exhibited significant responses, either as measured as the evoked potential or high gamma power to those vowels across the 3 states. So there are several take-home messages from this figure. Number 1 is that the activation is really quite extensive. So in an active listening task, when you listen to complex stimuli, the extent of cortical activation is pretty broad. Further, the biggest changes across states of awareness occur in the prefrontal cortex and then in the auditory-related cortex. Finally, high gamma responses are much more focal. They're by and large limited to superior temporal plane and surrounding cortex on the lateral surface of the STG. This is just to give an idea of what the time course of these responses is, and as one would expect, the latency of responses increases as we go up in this cortical hierarchy from core to non-core to auditory-related cortex, and also as we transition from awake to sedated condition, basically we lose contribution of sites in prefrontal cortex followed by auditory-related cortex. So one might say, well, in the previous 2 slides, I basically just added up all the electrodes I had. Well, I might be biased by my electrode coverage. As a control, I'm also presenting this analysis as fractions of how many sites out of the total coverage exhibited significant responses to these vowel stimuli, and this is shown here. So several take-home messages are, number 1 is, in general, the proportion of responsive sites decreases as we go up in the auditory cortical hierarchy. Number 2 is transition from awake state to sedated state is associated with loss of involvement of prefrontal and auditory-related areas, and loss of consciousness is associated with further increase of involvement of these higher order areas, as well as some loss in the involvement of core auditory cortex. So those sites that still respond to these sounds upon sedation and loss of consciousness, they of course undergo changes in the way they respond. Specifically, the loss of consciousness is associated with a decrease in the magnitude of the evoked potential, and that's shown here, normalized across and averaged across all these sites, across these different regions of interest. So again, we see that there is, in general, a progressive decrease in amplitude even in the awake state, and upon loss of consciousness, we find significant changes that mostly, well, they really happen throughout the processing hierarchy. And when we look at latencies essentially exhibit the opposite pattern, where the latencies of responses increase systematically. Finally, I brought your attention to this feature of cortical response that we see in primary auditory cortex, and that is tracking the temporal envelope of the auditory stimulus. So we also sought to check what happens to that feature of the response, and we did that by pressing the wrong button on the remote, evidently, and using autocorrelation analysis to establish the accuracy of that envelope tracking. And what we find is that it is by far the strongest in primary auditory cortex, and it doesn't really change very much when we undergo transition from awake to sedated state, but it does decrease upon loss of consciousness. So to summarize our findings so far is we find that in the awake state, evoked potentials basically are found throughout the brain. High gamma activity, in contrast, is more restricted to proper auditory cortex, and in addition, we also see these robust envelope-following responses. Sedation is associated with a decrease in number of responsive sites in the higher order cortical areas, most notably prefrontal cortex and auditory-related temporoparietal cortex. Loss of consciousness is associated with further decrease in activity in these regions, as well as a decrease in envelope-following responses in core auditory cortex. And in general, we were somewhat surprised to find that activity within auditory cortex, both in sedated and unconscious states, is remarkably robust compared to what we have previously seen with click-trained stimuli. So overall sensitivity, as we saw, to propofol increases along this processing hierarchy in the auditory system. And I would argue that this attenuation of activity seen in prefrontal and temporoparietal auditory-related cortex has the potential of serving as a biomarker for loss of consciousness under general anesthesia. And we really seek to pursue these studies and examine changes in sensory processing that are associated with different kinds of anesthetics and also natural sleep. And with that, I would like to thank you very much for your attention. I would like to acknowledge my collaborators at the University of Iowa, University of Wisconsin, and Albert Einstein College of Medicine. Thank you.